Today's topic of our lecture is thyroiditis. Thyroiditis means the inflammation of the thyroid gland, and whenever there is an inflammation of the thyroid gland, there are the chances of the enlargement of the thyroid gland due to that inflammation. So the enlargement of the thyroid gland is the thyroid goiter. So it is not necessary that every time the thyroiditis will result into the thyroid goiter. But most of the time, the inflammation increases the size of the gland, resulting in the thyroid goiter. So either it is generalized, it is a smaller, or it is a larger in size. But thyroiditis may lead to the thyroid enlargement. So the inflammation of the thyroid gland, that is thyroiditis, there are different types of thyroiditis. One is the autoimmune thyroiditis, which is of two types: chronic lymphocytic thyroiditis, Hashimoto's thyroiditis. Other is the granulomatous thyroiditis, which is, we call it a Quervain's thyroiditis. Third one, fibrosing thyroiditis. We call it a Riedel's thyroiditis. And infective thyroiditis, either due to the bacterial infection or due to viral infection or other microorganisms. This is infective thyroiditis is divided into the acute thyroiditis and chronic thyroiditis. Acute thyroiditis may be of bacterial origin or the viral origin. So it may be bacterial thyroiditis or the viral thyroiditis. And the chronic one, which is lasting for a long time, it is maybe due to tuberculosis or due to syphilis. So these are the different types of thyroiditis. And now we have to discuss about the autoimmune thyroiditis. The autoimmune thyroiditis, this is a very common condition and it is associated with raised titers of thyroid antibodies. As I've told you, it is an autoimmune. So autoimmune, cause of this autoimmune thyroiditis is the presence of the thyroid autoantibodies, which are acting against the thyroid tissue. So this condition, which is, we call it autoimmune, it is associated with the increased level of the thyroid autoantibodies. The patient of this autoimmune thyroiditis will present with a multinodular goiter. This thyroiditis, the patient has the multinodular goiter. It may present as a discrete swelling, means most of the time this thyroiditis, patient of thyroiditis, autoimmune thyroiditis having a multinodular goiter, but sometimes patient may have a solitary or single swelling or single thyroid goiter, nodule. And primary myxedema without detectable thyroid enlargement represents the end stage of the pathological process. Initially, there's no myxedema, but later on there develops the hypothyroidism, and which will lead to the myxedema. Okay. Now, clinical features, how the patient of this patient will present to us. What would be the clinical features of autoimmune thyroiditis? The onset of the autoimmune thyroiditis may be insidious, means gradual, is asymptomatic or sudden and painful, that it resembles the acute form of the granulomatous thyroiditis. The onset may be gradual, is asymptomatic, means it is present for a long time, but it is asymptomatic. And the onset is gradually occurring. Or it may be sudden in some cases. When it is sudden, onset is sudden, then it will present with a painful swelling. Okay. Mild hyperthyroidism may be present initially. At the initial stage of the disease, there may be the mild hyperthyroidism, means thyroid hormone levels are increased. But hypothyroidism later on develops, either it develops rapidly or slowly. The goiter is usually lobulated, means there are multiple lobules of that goiter, and sometimes may be diffuse or localized to one lobe. The goiter may be large or small, soft in consistency, rubbery or firm in consistency. The thyroid goiter, due to this autoimmune thyroiditis, may be larger in size or small, but the consistency may be soft, rubbery or firm. It is commonest in the women at their menopause age. Papillary carcinoma and malignant lymphoma are occasionally associated with autoimmune thyroiditis. Usually the papillary carcinoma and malignant lymphoma may occur in association with autoimmune thyroiditis because of the same type of origin of malignant lymphoma and papillary carcinoma. Now, how you will diagnose the case of autoimmune thyroiditis? So first of all, the thyroid function tests like the T3, T4, and TSH are of diagnostic value. And raised titers of one or more thyroid antibodies are present in 85% of cases because it is an autoimmune disorder. So autoantibodies against the thyroid tissue are present. So we can find out the raised levels of the autoantibodies in the serum in 85% cases of autoimmune thyroiditis. FNAC is performed, fine needle aspiration cytology, which is most appropriate investigation to find out either it is a benign swelling or malignant transformation has been started like the malignant lymphoma or papillary carcinoma. Differential diagnosis of autoimmune thyroiditis is from the nodular goiter, carcinoma of thyroid, and malignant lymphoma. Okay, but it is not easy. It is very difficult to differentiate. But FNAC will help us to differentiate between this benign autoimmune thyroiditis from the carcinoma, papillary carcinoma, and malignant lymphoma. When there is doubt about the neoplastic disease, which may coexist, which may occur in association with this autoimmune thyroiditis, then operation surgery is mandatory because we have to remove the malignancy. Uh, what is the treatment of this autoimmune thyroiditis? Thyroxine should be given to treat the hypothyroidism. Means, as I've told you, the later on this disease, hypothyroidism is a manifestation. So to treat the hypothyroidism, we have to give the thyroxine supplementation. If goiter is large and asymptomatic, it may subside with hormone therapy. We started the thyroxine and thyroxine level is covering the hypothyroidism. So there are the chances that the goiter is large and asymptomatic, so it may subside with this hormonal therapy. Long-term surveillance is necessary because of the risk of the late thyroid failure. So we have to keep the patient on the long-term follow-up uh, because there is a risk of thyroid failure, means hypothyroidism, severe type of hypothyroidism, later stage. If goiter increases in spite of hormone therapy, and in these conditions, there may be favorable response to steroid therapy. The goiter is increases. We have started the thyroxine, the thyroid hormone therapy. In spite of that, the thyroid increases, goiter increases in size. So as you know, this is an autoimmune disease. So we have to start the steroids. The steroids will get the good response to this disease because it is an autoimmune. Autoimmune disorders usually respond to steroids. Thyroidectomy may be necessary if goiter is large and causes discomfort. We remove the thyroid tissue, we go for a surgery like thyroidectomy when goiter is large one and it's cosmetically it is problematic, it doesn't look good and this is causes discomfort or pressure effects like the dysphagia, dyspnea and the hoarseness of voice because of its pressure effects. If goiter increases in size and is not responding to treatment of the steroids and the thyroxine, hormonal therapy, this may be due to the development of malignant lymphoma. So it means if it is not goiter is not responding to medical treatment, so there may be the chances that it may have converted into the malignant lymphoma. So we have to detect out this at this stage. Now another type of the thyroiditis is the granulomatous thyroiditis. The granulomatous thyroiditis, this is the causative agent is the virus. It's a viral cause. This is the mumps virus is responsible for its occurrence. Patient may present by pain in the neck, fever, and malaise. These are all features of the viremia. These are the features of viral infection. Whenever there is a viral infection on our body, we feel a pain, we feel a fever, malaise. So these are the features of the any viral infection. The patient is the pain in the neck and fever and generalized malaise. Patient may present with firm, irregular enlargement of one or both thyroid lobes. And there is the raised ESR because of the viral infection and thyroid autoantibodies are absent because it is not an autoimmune disorder, it is because of the viral infection. So diagnosis of this is confirmed by FNAC, radioactive iodine uptake, and by a rapid symptomatic response to prednisone. Viral infections usually respond to the steroids. So whenever we will start the prednisolone, the steroid, the patient's symptoms will be subsided. It will give the response, symptomatic response to prednisolone. And it is also one of the indicator that it is a viral infection because it is giving the good response to the rapid response to the prednisolone steroids. And further, we do the FNAC or the radioactive iodine uptake, and radioactive isotope scaling will confirm it as the proper diagnosis of this thyroiditis. Treatment for acute case with a severe pain, prednisolone is given 10 to 20 milligram daily for 7 days, and the dose is then gradually reduced over the next month because the way we start the steroids with a loading dose, then we have to decline the dose gradually. This is the principle. Serum T4 is high in this viral thyroiditis, normal or slightly raised. Radioactive iodine uptake of the gland is low. When we will go for a radioisotope scan, the radioactive iodine uptake of the gland is low. The condition is self-limiting because it is viral. Most of the viral infections are self-limiting. They will subside by themselves. So the condition is self-limiting and goiter has subsided in few months. Subsequent hypothyroidism is very rare. In 10% of cases, the onset is acute goiter, very painful and tender, and there may be symptoms of hyperthyroidism. 35% of the cases are asymptomatic, but presence of the goiter is there. And other type is the Riedel's thyroiditis. Riedel's thyroiditis, it's a rare condition. It is a rare condition and occurring only in 0.5% of the goiters. Here the thyroid tissue is replaced. Basically, what happens, what is the mechanism, what is the pathophysiology of this Riedel's thyroiditis? Because of the thyroiditis, inflammation of the thyroid gland, later on there will be the proliferation of the fibroblast cells. Means thyroid tissue is replaced by the cellular fibrous tissues, which infiltrates through the capsule into the adjacent muscles, paratracheal connective tissue, and carotid sheaths. So here the main tragedy is that though it is a very rare condition occurring in 0.5% of the goiters, but the thyroid tissue after the inflammation later on there is the increased proliferation of the fibroblasts. The fibrous tissues are increased in concentration. So when the fibrous tissues are increased, the thyroid epithelium is replaced by the cellular fibrous tissue. And that fibrous tissues will infiltrate through the capsule of the thyroid into the adjacent muscles, paratracheal connective tissue, and carotid sheaths, leading to the very much adherence formations because of this fibrosis. And this Riedel's thyroiditis may occur in association with the retroperitoneal mediastinal fibrosis. So it is a collagen disease. Goiter may be unilateral or bilateral and is very hard and fixed. Hypothyroidism is common in this condition. The differential diagnosis of Riedel's thyroiditis is from anaplastic carcinoma. Diagnosis is confirmed by wedge biopsy of the isthmus. Because as you all know, here the differential diagnosis is from anaplastic carcinoma. What is the characteristics of anaplastic carcinoma? It's a very advanced disease. It's a very advanced disease, and in this, the thyroid tissue is very hard, adherent, densely adherent with the trachea and the adjacent muscles of the neck. The similar appearances, similar condition occurs because of the Riedel's thyroiditis due to excessive fibrosis. The excessive fibrosis, there is the lot of proliferation of the fibroblast cells, and that will lead to the fibrous tissues, excessive fibrous tissues formations. And the thyroid, normal thyroid tissue is replaced by these fibrous tissues, and then these fibrous tissues penetrate through the capsule of the thyroid and they spread enter into the adjacent muscles, paratracheal connective tissues, and carotid sheath of the neck. So what these fibrous tissues we call, they become adherent. The thyroid gland is adherent along with the adjacent paratracheal connective tissues and the adjacent muscles. So because of this fibrosis, the thyroid tissue, the adjacent muscles, the paratracheal connective tissue, and carotid sheath, because of this fibrosis becomes adherent, densely adherent, forming a very firm consistency, and that thyroid is immobile. So same is the presentation of the anaplastic carcinoma. The anaplastic carcinoma, we will discuss in the next lecture the different varieties and different types of the thyroid carcinomas, in which we will also discuss the anaplastic carcinoma. It's a very advanced, adherent, and poorly differentiated carcinoma of the thyroid, in which the thyroid tissue becomes very hard and densely adherent with underlying structures. That's why, because of this similar presentation, Riedel's thyroiditis is always differentiated from the anaplastic carcinoma. So the anaplastic carcinoma is the best way to confirm the diagnosis. Either it is the Riedel's thyroiditis, fibrotic thyroiditis, or it is an anaplastic carcinoma. We take a wedge from the thyroid tissue. We call it a wedge biopsy. We take a piece of the thyroid and get it for histopathology, and that is, we call it a wedge biopsy, and we have to easily to get it from the isthmus of the thyroid, and this wedge biopsy is then sent for histopathology. That will confirm is either it's an anaplastic carcinoma or it is a Riedel's thyroiditis, because the Riedel's thyroiditis has some resemblance with the that is, we call it a anaplastic carcinoma. This is all about the different types of thyroiditis. Okay, so now regarding the infective thyroiditis, the infective thyroiditis is, as I told you, uh, as I told you, okay, infective thyroiditis, the cause is bacterial and the viral. And as if it is infective thyroiditis due to any bacterial infection, and we have to treat it by the broad spectrum antibiotics, and by the broad spectrum antibiotics, this acute bacterial thyroiditis will be resolved completely, and there are the less chances of the enlargement of the thyroid tissue. So in case of acute bacterial thyroiditis, there is no thyroid enlargement or very small thyroid enlargement, means the thyroid goiter will not persist for a long time. If there is a slight enlargement or slight swelling of the thyroid tissue, that is because of the acute thyroiditis due to bacterial infection. When it is treated by broad spectrum antibiotics, later on that thyroid swelling will be resolved, and thyroid swelling will disappear after the treatment of this bacterial thyroiditis. And but at when its onset is sudden, and it is presented with a fever, with a pain in the neck, fever and swelling. But by the treatment of broad spectrum antibiotics, the pain will be reduced, and the fever will be subsided. And later on, when it is cured, the swelling, enlargement of thyroid gland will be reversible. The thyroid gland becomes normal. Same is with the viral thyroiditis. It is acute viral thyroiditis is treated by the bed rest, the paracetamol, and sometimes if it is very severe pain and having the high-grade fever with the discomfort and swelling, then we start the steroids, because the steroids has got the good result in cases of viral infections. And if it is a acute viral thyroiditis, it is self-limiting. It will subside automatically after 1 to 2 weeks, and then later on the patient will be normal, and the thyroid swelling will be normal in size. There will be no thyroid enlargement. In cases of chronic thyroiditis, that is lasting for a long time, it is causes tuberculosis. Though the tuberculosis is very rare of the thyroid tissue, but if it is due to tuberculosis, the biopsy will confirm us that either it's the tuberculosis or not, and then we have to keep the patient on the anti-tuberculous drugs for 8 months, and it will be cured. And syphilis is a very, very rare condition in which there is the thyroid tissue is involved. So usually the thyroiditis, like the acute thyroiditis and chronic thyroiditis, are treated by the conservative treatment, and like the autoimmune thyroiditis, and these all are medically treatments are there. But in case of a very large enlargement or a big goiter, multinodular goiter, because of the thyroiditis lasting for a long time, because of the cosmetic effect, because of the discomfort produced by this large size of the thyroid goiter, enlargement surgery is advised. We go for the thyroidectomy, but there are certain indications of thyroidectomy if the post-thyroiditis thyroid goiter is very larger in size, that has developed into the multinodular goiter, and it is causing the pressure effects like the dyspnea, dysphagia, and hoarseness of voice, and very causing the discomfort to the patient. Then the indication is of the surgery is we have to go for the thyroidectomy. If it's the thyroid tissue is very similar in size, thyroid goiter because of the thyroiditis, it is very similar in size, not causing any discomfort, no cosmetic effect, then we have no need to go for the surgery. And especially the autoimmune thyroiditis responds to the steroids and hormonal therapy. Similarly, the acute bacterial thyroiditis and viral thyroiditis and the chronic thyroiditis due to tuberculosis may be resolved and completely treated by the medications. So there's no need for surgery, but only in those cases in which the thyroiditis has occurred, but later on developed, patient developed the very large size multinodular goiter, which causes the pressure effects or the leading to the discomfort to the patient. So these are the indications for the surgery, and even in these cases of thyroiditis, we have to advise for the thyroidectomy.